Patients present with problems either due to an injury, typically sports, or degenerative conditions where the passing of time has led to tissues aging and just gradually slowly wearing out. If they're between, say, 20 and 30, instability is probably going to be the problem. The problems with the rotator cuff tend to occur later in life. We always say around about 40, people start noticing pain from their rotator cuff, which they typically feel here. It may only be when they lift their arm up and they get a sharp pain and they try and reach above shoulder height, or it may be at night it's particularly bad when they roll onto their shoulder. And later in life again, you start coming across patients with arthritic conditions, usually in their sort of 70s and 80s, but you can see it in younger people. The type of pain gives you a big clue as to where it's coming from. So-called epaulette pain is rotator cuff. Pain from the acromioclavicular joint is localized there. Rotator cuff pain often causes a background ache. If the shoulder is impinging, in other words, the rotator cuff tendon is catching on the undersurface of the acromion, the patient will often experience a sharp pain when they try and reach up above shoulder height. And typically that will pass off once they go through a so-called painful arc. So they lift their arm up and then they get a wince and give their arm a little rotation, and then suddenly it's free and they're fine. If they've got some arthritis in the AC joint, they'll often still experience pain high up there as well, and we call that a high painful arc. If I see somebody under 40 who's very sporty, they have probably overdone it, and the tendon has swollen slightly, so it's now rubbing, or the bursa may be inflamed. The bursa is a little slippery sac between the tendon and the bone, which can become inflamed. When I assess a patient, the history is the most important thing. I want to know what sports they do, what hobbies they have, what treatment they've had, whether they've had injections or physiotherapy. I want to know if the shoulder feels stiff. I want to know whether they've got instability, which patients may know it's unstable. They may describe that they can feel it come out of joint, but there is another presentation where they say that when they reach up to get things, their arm goes dead and drops to their side. Then I examine the patient, specifically looking for deformity or wasting of the surrounding muscles. Tenderness is a very useful sign from the soft tissues and the bones. The range of movement is really important compared to the other side. And there are specific tests looking for instability in the shoulder. So all that together with investigations, which are usually an X-ray and maybe an ultrasound or an MRI scan, enables one to reach a diagnosis. Once you've got the diagnosis, you can then recommend specific treatments, which might in the first instance be a steroid injection or almost invariably physiotherapy if they haven't had it already. We always treat patients conservatively initially because lots of conditions are self-limiting, so you shouldn't rush in and operate straight away. Although I'm a consultant orthopaedic surgeon, I don't operate on everyone that comes through the door. Probably 5% of patients I see end up having an operation. We make people better. There's very few people we can't help.